Hello, I'm Dave Kaiser, and I'm a professor and director of pharmacogenomics at Manchester University in Fort Wayne, Indiana. So you heard my title, pharmacogenomics, right? Why am I excited about that? Well, I'm really excited about it because precision, right? I mean, we have dosing options that we have for patients, but they're limited by strength. And when I think about compounding pharmacy, I always think about specifics. I think about the needs of the patients and how specific those can be, and whether or not we can actually get to those specifics. So I'm a trained pharmacist. I've been a pharmacist for 37 years, and really started down this precision path in 1998. Really following the Human Genome Project that started in 1990, and seeing where it was going, and connected it with pharmacokinetics, and then where did that lead, right? So I really think that from the compounding standpoint, um, we're going to have the opportunity to get more precise than we can right now. What I mean by that is currently there are guidelines for um, now probably 50 some medications. And there are recommendations to decrease doses by, say, 25%, 50%, what have you. But the dosage form and dosage strengths don't always, you know, work out to be very amenable to those kind of changes. And so compounding really is where you can get to those specifics. If there's a 25% reduction in dose that doesn't make sense from a dosage form standpoint, then here we go, right? We're ready to roll. And I think that's going to be the epitome of compounding pharmacy and pharmacogenomics and precision dosing. And I know the others might have mentioned this, but it's really going to be to the point where using the 3D printer kind of idea, we can get to specific doses for patients, those that are in a brittle, narrow therapeutic range for their medications, and that's something that can be done, right? From the standpoint of evolution, I guess you would say, is we went down the path of doing pharmacokinetics in the 70s and 80s. The technology came along there. And so, for instance, in the area of compounding certain hormonal therapies, or maybe even different route of administration for certain medications where there may not be pharmacokinetic data, what's the real endpoint? Well, we look at how the patient responds to the medication. I think there's a number of folks that say, well, listen, you don't have the pharmacokinetic information in between the dosage form that's being made by the compounding pharmacy and the response of the patient, and you don't necessarily need that, because you can see the response to the patient. That's the whole point, regardless of what the concentrations are. But when we talk about the opportunities with compounding and the technology that we have now to match specificities with different genetics, it really is like the I'm very biased towards pharmacogenomics, but it's like the panacea, right? It's like the summit. So that's where I see us going, and it's going to take a while to get there. It's really a slow uptake for pharmacogenomics, really because education is lacking. There are many other reasons. There are payer issues. There are certainly some privacy and social, ethical, legal implications. But the biggest is education, because education addresses all of those different things. The payers want to know more about pharmacogenomics, and they're starting to come around. United Healthcare, for instance, is broadening their pharmacogenomic test payment and reimbursement. Medicare, Medicare administrative contractors have made some coverage determinations to broaden payment for testing. So that's happening, but where is the interpretation and where is the application really happening? It's happening where those folks are educated to do it. And pharmacists are taking the lead in this. The major organization for pharmacogenomic guidelines is the Clinical Pharmacogenetics Implementation Consortium, vastly made up of pharmacists and physicians, but pharmacists are really leading the way. So I'm excited about pharmacogenomics, and I'm excited from the compounding aspect, because I think we can take it to another level than where it's going to be based on the kinds of alterations in patients' response to medications and the need for specific dosing.